What is diagnosis and initiation of the treatment and canonical to carving reduce signs of tissue deformities of the structures. So it's a combination of orthognathic and special surgery related to the tissue deformity of the mostly it can be seen after the completion. We can see a little bit effect on the next segment. So the jaws and aims to normalize the relationship of the jaws. Very efficient complex. Classification mandible deficiency. So will be there. The double system like cleft lip also. Facial symmetry. Facial hypertrophy and facial hypersomnia. These are the common. What are the this type of patients? Prominent and supplementary analysis of this corneal angle with the labium dental film cosmetic and maxillary mandibular deficiency or facial features we can see is convex profile. The torus seems so it's called best face deformity. We can see in the facial vertex and bed face, short upper lip, even the top lip, and sizes level fold acute corneal angle. And which is plastomyeloclusion, it's orthognathic. Antipoidal is deep dive. What other we can see? What is mandibular properties? What is called a mandibular properties? We can see mandible, so it's called a conical property. So in determination, you can see the mandible. What do you mean vertical maxillary? That means maxillary. So maxillary can increase the height of the jaw. In our base, recessive paranasal areas into cheeks, bones, and nose. Large interlabial gap, cometan lips, gummy smile. That's commonly seen in vertical maxillary. Deep mandibular plane. Violet with or without any. When you go for maxillary differential, you can see short square shaped face, decreased lower facial height required for mandibular due to the overclosure, deep window level before appearance of the gene, overclosure of the lips, class 1 or class 2 malnutrition, deep overweight, mandibular incisors. Attrition. In this diagram, we can see the first diagram. We can see the second bit is the deficiency in maxillary. The upper lip we can see very short, well like a straight appearance. What are the treatment plan for the orthognathic surgery? First of all, every patient will go for the initial assessment. What are the team combine of the patient and medical and dental history, clinical examination, the facial proportion, facial profile, and evaluation that is analysis, then surgical treatment plan. The case of treatment planning depends upon first you will go for the dental products. So first you will go for the fixation, and after that only we will go for the orthognathic surgery, and post surgical orthodontics will do. Then dental treatment will do. And aesthetic surgery like a rhinoplasty surgery will do. Objective for the pre-surgical orthodontics to relieve the arch crowding, to close spaces, correct rotations, to the alignment with the arches, control relapse and tendencies. Grows or close difference, and posterior teeth in the ideal relation to the dental recession imposed when surgical corrections of the jaw are eliminated, maximum surgical correction, and proper intra-operative control, proper post-operative stabilization. So pre-surgical orthodontics they will do for 3 to 12 months, depends upon the case to case basis. Post-surgical orthodontics will do 3 to 6 months. Most of the patients will be crowding into this type of orthodontics, then we can proceed with orthognathic procedure. What are the things we can do with mandible? Mostly the osteotomy, posterior body osteotomy, and emphasis osteotomy. So segmental, they're like anterior subapical, posterior subapical, and total subapical osteotomies. Genoplasty, that is to it, that is different types: augmentation, straightening, and lengthening genoplasty. If you go for the ramus, then the different is like a bilateral sagittal split osteotomy, extraoral vertical subsigmoid, intraoral vertical subsigmoid osteotomy, inverted L-shape osteotomy, arch ramus osteotomy, and C osteotomy. These are the types of osteotomy procedures do it in the mandible. So what do you mean genoplasty? Genoplasty, the method of correction of the gene permanence and the amount of which contains that simple reduction or reconing by bone sculpture, augmentation of by bones, onlays, or the addition of alloplastic materials, various forms of sliding osteotomy on the lower bottom. Reduction. Genoplastic reduction. There are two types: vertical and horizontal reduction. Genoplastic. Remove the subapical wedge of the bone and reposition of the lower border of these two. Put wire fixation between the cut surface of the labial cortical plate. Soft tissue are not detached to maintain viability to improve the post-op control. Next one is the augmentation procedure. That's called advancement is there. Horizontal also like sliding or double sliding procedures. Oblique cut is made below the abasis of the anterior teeth and carrying it downward below the metal foramina. So anterior lower is angle and downward bone or proplastic inserted to make up the recording disability. First, what they will do, there will be a cut. After that, just slide it. So, if suppose a patient has the mandible, at that time, the augmentation procedures like advancement we are doing. Diagram is the plastic procedures. One is where we'll cut. We can see for a vertical cut, for a horizontal cut from one side to other region, then pull it back and fix with the plates. Sometimes we'll do a double cut to increase the mostly the advances in movement. Next one, I'm showing the excess, mandibular excess is there, so we have to remove the bony part. So the for two cuts they will do and take out the portion, then fix with the plate. Suppose there will be deficiency of the mandible, then we'll place that graft, plastic graft, or like that, or the graft will place on that area. You can see in this diagram how that genoplasty done with the graft. Cut is placed, so it will never damage the mental lab. So we can achieve the vertical mandibular height. If you sometimes previously they were using with screws. After that they are using with mini plates for the fixation. Otherwise, previously they are using the wiring technique also they can use. So what are the complications on teaching a plastic procedure? Position of the graft relapse and periodontal defects we can see in this type of surgery. Types of ramus osteotomies. First one is the bilateral sagittal split osteotomy. Then vertical segment, inverted C-shape and oblique subcondylar osteotomy. So going for the bilateral sagittal split osteotomy, first introduced by Donner and Obligasis, and later the modifications by the lateral point and the handshake. It's a natural plane of the cleavage between the buccal and lingual cortical plates of the ramus is used to develop two sagittal splits separating the proximal fragments from the distal fragment, condyle and dental fragments. So it's a split between the mandible and you can see the diagram where they cut. You can see the mandible foramen. In front of the mandible the cut place and goes to the external bridge, and towards to the second molar they will put a vertical cut down, and we'll using with the Smith splitter to split it, and if you want to slide it we can move, or if you want to reduce the length, so cut the piece. The diagram they're showing is that orthognathic mandible, so that we don't do end-to-end patients mandible. So we've done the sagittal times that is called setback. We have to orthognathic mandible. We have to reduce that length, so we'll cut it off that much portion. Then pull it back to the setback. That's called so what we'll do here, we're going to cut now, cut it off and achieve the mandible. This is the older techniques that involving reverse inverted L Ramakrishna procedures. This is the osteotomy, various types of osteotomy procedures like inverted line, but in success of mercies, osteotomy, arching osteotomy like that. But mostly commonly used is sagittal split osteotomy. And parallel contact is under osteotomy occurs in sagittal split osteotomy, vertical subsegment, but everything. This is the subapical osteotomy. If a particular segment we want to, if the patient having the what we tell, patient occlusion is correct, but the patient under the anterior, lower anterior, or like that sub area will be want to achieve. Now, some at that time we're using that subapical osteotomy. So, in this diagram, we can see the patient having lower anterior protrusion is there, but other things the patient physics is everything normally. So we'll cut it off that osteotomy cut from the first premolar to the fourth quadrant to third quadrant. We'll cut it off and pull it back. So at that time, sometimes we have to take out the second premolar, then we can achieve the occlusion. So after the B diagram, they are showing the lower anterior region, pull it back and achieve the occlusion. Next one is the maxillary osteotomy procedure. What are the various types of osteotomy procedures? Maxillary, middle tooth, endosseous osteotomy, interdental osteotomy, anterior and posterior maxillary osteotomy. Total maxillary osteotomy is like a leaflet procedure, superior reposition, inferior reposition, horseshoe shape, advanced maxillary and leveling maxillary. So that is normally if the patient having the anterior overjet will be there now, then at that time we will do anterior maxillary osteotomy. So where will they cut? No, first you put the uh, buccal incision, vestibular incision will place from one side to another side and put a markings on the which area to that area. So we mostly will do it from the first premolar. So we'll cut it before cutting osteotomy procedure. We'll do extract it to first premolar. Then we'll goes to the lateral edge of the nose and we'll cut it off on the both sides and pull it back, set back. Then we can achieve the uh, vertical maxillary excess. You can see in the diagram how they will do. So sometimes we can do only the particular the posterior segmental only one side will be done, then we'll do the same procedure, but we'll cut it off only on that particular area, not on the both sides. For one osteotomy, one osteotomy is a procedure where first start on the lateral pressure below the uh, piriform. So the leaflet one osteotomy, where we'll start first the incision, the vestibular incision will be placed. After that, the osteotomy will be kept below the piriform region. So initial cuts in the buttress region, progressing towards to the nose, and next to the posterior cuts to the pterygomaxillary region kept inferiorly. So minimum 5 mm above the root apex, and the next cut in the sinus from the inside out. So same thing we'll do it on the both sides. It is we can see first The cut will start from the line of aperture, then will goes posteriorly and the pterygomaxillary region, this area. So the cut is going inside the sinus. After that, pterygomaxillary disjunction will split it. After that, using the osteotomy, will cut the nasal septum and everything. So the cut is like this, you can see. And lateral side also we will cut it off, both sides, and will split the maxilla. Then we setback or advancement like that will do it and fix it with the mini plates. So what's the indication mainly for this vertical maxillary access in the max protrusion and superior reposition of the maxilla to correct the open bites, advancements in the cleft palate and post-traumatic patients to correct the open bites, combined with the mandibular procedures, then advancement of the maxilla in the class 3 patients. The diagram showing the leaf or two orthognathic. This type of surgery mostly will do the craniomaxillary defects, mostly seen you can see in that syndromes related like Dutch-Coin, Down syndrome, all these type of patients. Craniofacial deformities will be there. Before the osteotomy also. This is the instrument we are using for the pulling the maxilla, that is called a cross disinvasion forceps. This instruments are called the osteotomy. You already know that what is the difference between osteotomy and chisel. Chisel is monobevel, osteotomy is bibevel. So what are the complications we can see in intraoral? Mostly unfavorable osteotomy cut will be there, hemorrhage bleeding will be more, difficult in positioning and the fixation, and the nasal and airway problems and damage to the teeth. Right? We will cut it off the root of the cancer. Post-operative complications, that's the most commonly seen. Relapse will be there, maxillary settling, transverse relapse, condylar distraction, bleeding from the surgical defects, infection, non-union. These are the commonly seen after post-op complications. You can see in this diagram maxillary advancement and mandibular setback. Patient have a deficiency of the maxilla, we want to advance the maxilla and we want to set back the mandible, then only we can achieve the patient's profile. So like that, there are various type of surgeries are there. Suppose the same thing if the patient having maxillary access and a patient having orthognathic mandible. So the procedure normally we go for the Leopard 1 osteotomy or AMO depending upon the model analysis and symptomatic analysis. So after that we will go for the bilateral sagittal split osteotomy. And there is one more technique called visor osteotomy. Visor osteotomy, if you want to a particular segment of the tooth we want to do, then we will go for the visor osteotomy procedures. The Leopard 2 and 3, they are commonly used for the craniofacial defects problem. But normally, in a normal orthognathic point of view, what the most big thing is particularly maxillary, the vertical maxillary deficiency, mandibular access, mandibular deficiency, orthognathic mandibular. This type of patients will be we go for the Leopard 1 osteotomy because also or genoplasty like that. But some cases the treatment will be changed depend upon the Like there's a I don't think so you heard about the sleep apnea syndrome. In sleep syndrome, the patient having orthognathic mandibular and the patient can difficulty in breathing also, like double chin and a bird's face, and so that time we will go for the A41 osteotomy, BSO, and genioplasty procedures too. So what's the advantage? The tongue will never fall back, so there will be no difficulty in the breathing problem like that. So we can achieve the patient's airway also. These are the main things we will do. One is genioplasty and A41 osteotomy. This is also the cut will set from the in front of the preserve first that the stool incision will place and reflect up to the corner region, then reflect and preserve the imperial nerve, then will cut will place the middle to the uh, in front of the foramen, and cut goes to the external orbital and goes to below the up to second molar, then going downwards. And then we'll use the Smith spreader and split it, and we'll go for the setback or advancement for the lateral aperture back for distinction. Mostly, and one more thing I want to tell you, what's the difference between input one output and default one is we have cut the segment up to the maxillary distinction area, but the fracture that will go to the lateral plates also. That's the difference. I think about it. And genoplasty, there are different types. Yeah, advancement, sliding, accommodation procedures. So this is the topic regarding about the orthognathic. Thank you.